All right, so spicy strokes. So spicy strokes are ones that where you give thrombolytics, right? So thrombolytics are given within how many hours? Within 4.5 hours, right? It used to be 3, and then now that's why you always see it say 3 and 4.5 hours. Like why you guys just change everything to 4.5 now to make everybody's day easier. But there are more complications if it's after 3, so I guess there's some kind of data somewhere that they're tracking about that. But either way, they have to meet criteria, right? So one of those criteria is blood pressure less than 185 or 110. If it's repeated more than 185 or 110, sorry, you don't meet criteria anymore. Other reason why you would meet criteria is you had a recent head injury or anything neurospinal in the last 3 months. You're not a risk, you're too high risk. You're not a candidate for thrombolytics. And just straight up bleeding risk, right? You're on anticoagulants. You are and we did some coags, and your coags were super prolonged. It's going to take a while to reverse those coags, right? And if you reverse those coags, you might get a clot, ironically, right? Because when you give like PCC, you give those other things that coagulate. It's like, well, is that going to help the situation or worsen it, right? So unfortunately, they're not a candidate if they are hypercoagulable, or I should say, have coagulopathies, if they are very, very thin on their blood, right? And then they got evidence of ICH. Well, that's number one, right? If you have intracranial hemorrhage, we're not going to give a thrombolytic because your body is trying desperately to make clots, right? To avoid the spillage of blood into the brain tissue, right? So if we give thrombolytics, which go ahead and bind to our natural plasminogen, they're called tissue plasminogen activator. They activate tissue plasminogen in the tissue, and they're going to do its thing, which is to create plasmin. What plasmin does is break down clots directly, right? On the clotting cascade side, we had fibrinogen that made it into fibrin via all these different coag cascade, intrinsic, extrinsic pathways, right? But then eventually you had a fibrin mesh, right? You have a fibrin mesh right there, and eventually gets cross-linked about 4.5 hours. So we want to A, be within 4.5 hours, and B, we want to make sure that we're going to be activating plasmin, right? So plasminogen activates and turns into plasmin, and that is going to break down our clot, right? This is why, like, as D-dimers there, that's fibrin split products, or that's what happens, PE, we measure D-dimers, right? D-dimers are fibrin broken down, right? So that shows you that your body formed a clot, and your body's like, oh shoot, why is there a clot there? And it starts breaking it down, right? So we have tissue plasminogen activators, and we also have TNK, or tenecteplase. So tenecteplase is the new guy on the block. Does it cost more or less than TPA? It actually costs less, right? So it's still like $8,000. So pharmacies still, like, they bat an eye every time you say, hey, we got to give TNK. Are you sure? Right? So you got to make sure the criteria are met here, right? So yeah, I'm sure blood pressure is good, no bleeding, coags look great, right? This is actually a stroke. The blood sugar is good, right? So the CT scan is what, negative or positive for stroke? It's negative, right? It means it has no ischemia and it has no hemorrhage, right? That means it's a candidate for TNK, or it's a candidate for thrombolytics. Okay, so we have options of TPA or TNK. Does one work better than the other? Absolutely not. Does one have better mortality than the other? Absolutely not. They're exactly the same mortality. They both have a 7% risk of dying. If you give that medication IV push, they could die 7%. 7 out of every 100 patients you get, 7 of them could die if you give this medication. So they have to sign a consent that I'm going to give this medication. It might work, it might not, but you could also die. So and then how many people actually have a benefit from this medication? 30%. Right, so out of 100 people, only 30 of them are actually going to have a benefit from the medication itself. So they have to consent to this, right? And obviously the drug companies, they sell like, oh, you're never going to jog with your kids again. Yeah, but you also can't jog with the kids, you're dead. But anyways, you have a medication that is available to us that can also, hopefully bust the clots, right? So they have to recognize these risks, right? So it's not just something we throw around. It's something, yes, it's expensive, but we got to make sure that we are giving it to the right candidate. Because as we mentioned on the NIH stroke scale, right? If it's too high or too low, it's not good, right? If it's too low, that means they barely have a lack of sensation on their hips. I can live with that, right? If a scale 1 to 4, my NIH, that's perfect, right? Or that's not perfect, but hopefully I can recover with PT, OT, etc. But if they have like severe deficits, or not severe, I should say they have significant deficits, then maybe it might have good outcomes, right? But if it's severe, like NIH greater than 26, I think, or 32, somewhere in there, then that could cause a actual hemorrhage in of itself, like guaranteed. So we want to make sure we're in the sweet zone of our NIH stroke scale. All right, you got 0 to 42. Right, you want to make sure we're in the sweet spot there. That's where we give TNK and or TPA, right? Well, so why do we use TNK? It's not because it's cheaper. It's because it's easier to calculate, right? Because TPA, you give 0.9 per kilo max, 90 milligrams. Then you give 10% of it now, and the other 90, or is it 90% of it now, the other 10% over 1 hour. Right, so we were struggling about a couple slides ago with just 10% of 210, right? So that's so it's a hard math to do. Whereas you have TNK and you just do 0.8, 0.5, what is it? 0.25 per kilo, and one and done. IV push, done, right? But you can't like, oh no, let's take it back, because then once you give the IV push, then you're done, right? You can't take it back. It's in the body, it's activated. There's no way to reverse it, right? So what can happen? They could get hemorrhage. That's why we always be alert to any kind of acute change. We're always doing neuro checks afterwards, like nobody's business, right? How much business? It's about Q15 for how long? About 2 hours, right? There's a 24-hour period, so they should add up to 20 to 24. It should be like Q15 times 5, and it's like, I got a 35-hour day. All right, no, it's Q15 for 2 hours, Q30 for 6, right? So that's 8, right? We're using our math skills now. What's left? Got 16 hours left, right? And the rest of that day is Q1, okay? So it's Q15 times 2, Q30 times 6, and then Q1 hours for the rest of the time for 24 hours. After that point, it can just be regular strokes, vanilla strokes of just Q4 hours, our neurochecks, right? And the next slide will describe what actual neurocheck entails. But definitely for spicy tapatio strokes, right? You need to make sure we are giving tapatio tectoplays. We are going to need to make sure we have our stroke scale being done and our neuro assessments being done, right? Which one is done Q15? The NIH stroke scale? No, that's once you finish after 15 minutes. Like, okay, now let's raise your arms up again, right? You're going to be there for a while. So the NIH stroke scale is done before, so we can get a number, so you know that it's they need it or don't need it. The provider is going to get that number as well to decide if they're a good candidate for it in the first place. And then afterwards, 1 hour afterwards, we're going to be doing the NIH stroke scale to assess if they are getting there is efficacy or not. And then after that, usually every 4 hours for NIH stroke scale. Q4 hours. But just a straight up neuro check where you're doing GCS, level of consciousness, you're doing neurovascular assessments, or not so much neurovascular, but neuromuscular assessments. These are ones that are going to be done every 15 or 30 or every hour. Okay. And like I said, the BP after administration needs to be not 185, but 180 over 110, and needs to be maintained for the whole period of time, right? For a whole 24 hours. So if you need to, we need to give IV pushes or a IV drip of what? Nicardipine, right? So we might need a drip, drip, right? And also, what's Angelina Jolie doing here? You can have Angelina edema. You can have angioedema that can happen as well as a significant side effect of tenecteplase or TPA. All right, then going back to other things we need to do besides neuro checks and such is we need to get all of our sticks and pokes and procedures done before we give the medication, because you're a high bleeding risk afterwards, because you can no longer clot efficiently, right? Because you can form a clot perfectly fine, but you have all this breakdown. So you form it, it's going to zap it away immediately, right? And then CT head needs to be done in 24 hours, or if you have a acute change, right? So you develop an ICH, so acute change, then it's time to get a CT scan immediately to make sure that they haven't developed intracranial hemorrhage. Has it happened? Yes, it's happened multiple times where you have to take a patient and post TPA. So they're really easy patients. They're awake and alert. They're on their phone. They're with families, but then they need to be assessed and woken up to make sure they're not getting any kind of further deficits to being developed. Okay, and then no anticoagulants or aspirin or antiplatelets for at least 24 hours. At the 24-hour mark, we can do a CT scan just to make sure everything's good, and then at that point, we can then give aspirin and or anticoagulants, right? Just like you would not give aspirin to a GI bleed, you would not give aspirin to an intracranial bleed. And how do you know they don't have intracranial bleed? That's what a CT scan is for. We're looking for that 7% mortality, but what's the hemorrhage risk is a little higher right? But we're looking for a possibility of hemorrhage. Okay, so as a recap, last known time well, less than 4.5 hours. Well, first, you got to check, make sure the blood sugar is good. And then we're going to get a CT scan, right? You do a CT scan by ACLS criteria within how many minutes? 15 minutes, right? Is when you need to get to, or 25, sorry, 15 minutes, you got to recognize that something's wrong. But 25 minutes from the time you recognize something's wrong, you have to then have that CT scan done, right? So that's why I kind of think 15, but 25 minutes, it needs to be done. Does it need to be read at 25 minutes? No, it needs to be read at 45 minutes. And then now we have 15 minutes to give this drug, right? Make a decision and give the drug or not. In that 30 minutes of waiting for the scan to be ready, we're doing NIH scales, we're getting the drug ready to go, everything's ready to go, so we can have that final image come across, and we can decide, was the CT negative, right? If it was negative, meaning no ischemia, no hemorrhage, then yeah, go for it, right? Of course, as long as you have an order and there's no contraindications, right? Oh, you're giving it, and you give it IV push. Like, you know what? I had the same sensation when I had my surgery last month. What? What are you saying? All right, so that's, you got to make sure that everybody's very clear that they don't meet any kind of absolute risk, absolute contraindications. All right, so ischemic stroke summary. So what are the things we're doing for ischemic strokes? Not hemorrhagic strokes, but ischemic, right? So the goal is time is brained, right? So 4.5 hours is the goal. You have up to 24 hours. We can do a VAN assessment, right? So VAN assessment, right over here. So if it's a large vessel occlusion, that's where you have a VAN. What's V stand for? You got a vision change. They got a gaze deviation of some sort. They got an A for aphasia, right? They have a talking problem. They have a, not like they're talking your ear off, but they have a dysarthria problem, or sorry, more of a word finding problem than dysarthria. They're not able to form words. And then you have the N for neglect, right? So are they neglecting half of their body for some reason, right? So any one of those positive, and of course the NIH stroke scale needs to be pretty decent, 6. All right, then we can go ahead and do a IR to do embolectomy. They can go in there, they can take the clot out, all right? And that's up to 24 hours after the last known time well. You can also do it if they failed thrombolytics, right? So they failed thrombolytics, then you can also do large vessel occlusions and evaluations and get possible thrombectomy. All right, so within 10 minutes, we're doing a whole workup. We're doing all the ACLS stuff. They're doing EKG, yeah, sure, but we're doing a glucose for sure to make sure that glucose isn't the whole cause of this problem, right? And then 25 minutes, we got that CT head, like we mentioned in the previous slide. And then within 60 minutes, we're treating anything that we need to, right? Because remember that 15 minutes, you got the CT read. We know if they are going to be a thrombolytic candidate and the blood pressure is like 215, 218, we probably should have something ready to go. And then it's a double-edged sword. It's like, what if the CT comes out positive, but I got the blood pressure down to 175, but I'm supposed to have permissive hypertension? So, it's a little gray area, no pun intended, right? So you want to make sure that our CT is good, right? And then we're going to treat appropriately. If it's hemorrhagic on the CT, it's just thoughts and prayers. There's nothing you can do about hemorrhagic strokes. All right, they just let them bleed? No, you have to make sure they don't bleed a lot. So you get the blood pressure down to about 140 to 160, and you say, you got this, champ. We're going to monitor, avoid any kind of secondary injury, make sure there's no hypoxia, no cerebral edema, all these things, and they can deteriorate very quickly. So we'll talk about hemorrhagic strokes briefly, right? But going back to ischemic strokes, if they have an ischemic stroke and it's less than 4.5 hours, we go and hit them up with some thrombolytics within 60 minutes of recognition of the code stroke, and then we go ahead and proceed from there, like we mentioned, right? And otherwise, if they get say a TNK, they have the spicy documentation where you are doing Q15 times 2, Q30 times 4, and then the rest is Q1 for that 24-hour period. And this is what you are documenting, right? You're documenting vital signs, right? Oftentimes you get missed, right? We have a stroke coordinator, and she's going to make sure that you document all 4 of those. Like, oh, you forgot your stats, we fell out, right? Or you forgot to document your respiratory rate for some reason, right? So you got to make sure we document all the vital signs and all these pieces of the neuro assessment, right? So GCS, level of consciousness. We got the orientation, 8 times 2 or times 3 or times 4. We have speech, facial symmetry, and PERLA. You got a pupil assessment. Sometimes we'll forget a pupil assessment, and we'll forget cranium 2 and 3, but we did 4 through 12. Does that count? Nope. All right, so it needs to be cranial nerve. It needs to be PERLA is what they're looking for. All right, and then we have a neuromuscular assessment. So what's their strength like, right? We're looking at motor function. Okay, and then we have, what are some things we're doing inpatient-wise? We're doing neuro checks by default, Q1 hour. If it's a regular vanilla stroke, it's Q1 hour neuro checks. But if it's a spicy stroke, that's where we're doing TPA or TNK, right? Just thrombolytics. And then we're going to get PT, OT, speech language therapy involved. And that's in every single stroke patient. Even if they have no deficits, they need to be evaluated. It's a core measure. It's a guideline that has to be done for every stroke patient admitted to a Medicare hospital. And we're a Medicare hospital. It's how you get reimbursement, all the money and such. So they got to make sure everything matches these guidelines, right? Same thing for like sepsis. For stroke, it's very, very structured. Okay, so PT, OT, speech language pathology has to be involved, and we got to get an aspirin in that body any way possible, right? If the speech language pathology is not there on a Saturday, but they're going to be there on Sunday before discharge, right? He's like, I need aspirin in this body, this human. How do I get it in there? Well, there's more than one hole, so you can also give it per rectum if you need to, all right? So that aspirin needs to be in there, but if it's a TPA, TNK patient, it's not within 24 hours anymore. It's after the CT scan's done, then you can get aspirin on board, right? VT prophylaxis needs to be in place so we don't get complications of immobility with, because the stroke patient can be immobile and comatose and in the ICU. So we need to make sure that they are on mechanico and pharmaco prophylaxis. They're on SCDs for mechanical support and also on pharmacological with Lovenox or heparin. Okay, and of course we're going to wait after that CT scan for TPA patients. All right, there's always like a but then, but if, right, if they got thrombolytics. That's what makes strokes a little bit difficult because it's not always clear cut. Ischemic strokes, you do X, Y, and Z. So you do X with an asterisk, Y with an asterisk, and you do Z, theta, gamma, alpha. But you have, there's certain things you always do. PT, OT, speech language therapy, that's for everybody, right? Statin is for everybody on discharge. For aspirin, it's pretty much everybody on discharge, unless they're allergic, right? Or you found they got a hemorrhagic conversion, for instance, and now that's hemorrhagic strokes. That's something different. Okay, so on discharge, like I mentioned, you're going to get a statin on board. All right, high dose statin. There's only two high dose statins. It's a atorvastatin or a rosuvastatin. And if they're on simvastatin, that's not right. That's not the right statin to be on. Okay, and we have DAPT. So the clopidogrel depends on what other underlying factors they might have. And if they have some embolic reason, they'll be on a DOAC, a 10A inhibitor, for instance, right? So these are all the guidelines that need to be followed to make sure we are doing like dysphagia screening. We do our nursing swallow screen, right? How many nursing swallow screens can you do? One, right? So if you do two, you're going to fall out, right? The second one always has to be done by a speech language pathologist. I even asked, like, well, what if it's a provider said it was okay to do it? They said, no, it has to be a speech language pathologist. So I'm like, what do they know more than the provider? I don't know what kind of education do they have. And I started like talking about like what degree. I looked up degrees on Google about speech language pathologists and like how many years of training do they get and how come a provider can't do it? Because sometimes providers are like, oh, sure, go for it. But oftentimes, sometimes there's a disconnect, right? Like the ER, for instance, did a speech eval on a patient immediately after intubation, after rocuronium administration. Like, oh my gosh, they failed. Oh shoot! So then the nurse and the ICU then went in to did a speech after they got extubated. They did a speech eval. Like they passed and get their meds. And the next morning, he's like, "What did you guys do? What do you got? You guys are going to kill this patient." It's like, yeah, they failed the first speech because they had paralytics. I would fail the speech too if I had the paralytics on board as well, right? So don't you think that's a thing? It's like, no, the box is already checked. You can't do that. So okay, all right. So there's some battles you can't win, right? And some emails you can't write. All right, so ischemic stroke complications. So we talked about, thrombolytic therapy. You can get a hemorrhage. You can have angioedema and such. Now we're talking about specifically ischemic strokes. So up here we have hemorrhagic conversion. That's with a significantly big stroke, a specifically big ischemic stroke. It can cause a weakening of all the vessels here, and the vessels we're held on by all these nice big protein sheaths, and we're held in place. But all of a sudden you have this drop in, what's the word? Not connection, but it's weak, right? Like concrete gets damaged in wetness, right? It starts breaking apart. It was not as strong anymore, and therefore CSF can start leaking and causing edema, and it can start leaking into the blood vessel lining, and they can rupture as well, right? So hemorrhagic conversion happens not only with TPA, with beyond 4.5 hours, but with just big ischemic strokes. And then cerebral edema for the same reasons. If it doesn't cause hemorrhagic conversion, it can cause cerebral edema because that area of the brain can no longer maintain its ATP and oxygen and other functions. Therefore, calcium gets loose, glutamate gets loose, and it can have widespread cerebral edema, especially in the area that has the lack of blood flow, right? And of course, that's going to be worsened. The surrounding area, the penumbra, will be worsened with hypoxia or hyperoxemia or hypohyperglycemia or hypohypercapnia. So these are all different things we got to keep normal post anything neuro, basically. There's no neuro thing where you're like, oh no, we want that one high. It's basically everything's pretty much the same. We're avoiding secondary injury. Okay, and then aspiration precautions. So these guys can't swallow. They can't talk, but they can't swallow good either. So we've got to make sure they're doing a nursing bedside swallow eval. One strike. That's it. That's all you get. All right. So then if they fail, it's no meds, no food, no exceptions, and it's until the speech language pathologist evaluates them. Right. And then aspiration precautions. So aspiration risk up top because they can't swallow good and they can't manage the food with their tongue good, and so they're easily able to aspirate. They can aspirate just acutely or they can aspirate chronically. So chronic disabilities are very, very common post-stroke. So we have a lot of people on disability because of strokes, a lot of lost revenue, a lot of lost wages because of the commonality of strokes. So if it wasn't from a chronic complication like being immobile or incontinence or something to that effect, there's a huge fall risk, right? They're weak, they have paralysis on one side, they have physical occupational therapy working with them, but sometimes the range of motion is not great and they can easily fall. And if they don't fall because of the weakness, they have spatial neglect, especially if it's like an MCA stroke. And then they have the visual fields being affected, whether it be a PCA or an MCA stroke. We have those guys are not working as well. Right? There's like a comprehensive list of all of our complications that can develop from strokes. But as we know, dysphagia puts you at another risk for aspiration, acutely and chronic. And then just being incontinent puts you at risk for UTIs if they have an ACA stroke, right? And then immobility. So they have all the consequences of immobility that we kind of touched on with ABCDF bundle for ICU, but they get contractures, they get VTs. That's why we do VT prophylaxis for these guys too. They get pressure ulcers, they get bone fractures, atelectatic pneumonia. They have atelectasis, and that develops into pneumonia after about 24 to 48 hours. So that's a problem that can develop with being immobile. There's all kinds of complications that happen just being bedbound, right? So yes, you made it through the stroke, but they are not going to have a meaningful recovery if they, of course, can't get the adequate PT, OT, speech therapy working with them as much as possible. And sometimes they're not alert enough to do those things, and they're depending on how big their stroke is, right? And so VT prophylaxis is indicated. And of course, depression, that's not you're not living your best life anymore. You're now stuck to a SNF bed or to home health or to the like, right? So we have what's called a Rankin score, and there's a modified Rankin score that includes depression as well. But this basically tells you, are you from a score from 0 to 5, how much deficits do you have? And this is what they use statistically to figure out what the kind of outcomes of strokes are. A 0 is great, you recover completely, whereas 5 is you're disabled, right? You're completely you're dependent on other people or nursing staff to get daily function completed. Okay, so here's another example of a stroke.
Also,
This is what a stroke looks like. She's a news anchor that started having symptoms of a stroke on live TV.
today at the event,
As you can tell, she's having a hard time getting the words out. News outlets reported that she was having some vision loss and numbness and tingling on one side of her body. And during that moment, she could tell that something was wrong.
I'm sorry, something is going on with me this morning, and I apologize to everybody. Let's just go ahead and send it on over to meteorologist Annie Brown.
When she went to the hospital, doctors told her that she was having something called a transient ischemic attack. This is still a stroke, but it's a short-lived stroke that resolves on its own without any medical intervention. And sometimes it's a sign that something bigger could be going on, and it warrants a further, more extensive workup. In the event that you think somebody might be having a stroke, remember the mnemonic BFAST. It stands for balance issues, eyesight changes, facial droop, arm weakness, speech deficits, and time. Time means time is brain, meaning the longer you wait, the more permanent the deficits could be. The sooner that a stroke is caught, the sooner we can resolve the stroke and the better prognosis the person will have. So if there's ever any concern that someone might be having a stroke, it's always safest to call 911.